everyone, my name is Claire Rooney. Thank you all for having me here today. I'm one of the occupational therapists here in Our Lady's Hospice and Care Services, and I'm the clinical lead for the newly established post-diagnostic dementia support service here, and that was established last year in 2019. And I work closely with Dr. Purcell, who also is over the post-diagnostic service. Today, I suppose what I am going to cover within my presentation is the service that we're offering here in Our Lady's Hospice. So that is a cognitive stimulation therapy group program to people with dementia, and also support for the carers of the people with dementia. I'm also going to give a background to cognitive stimulation therapy, and also look, I suppose, at our future plans in moving forward with post-diagnostic services here in Our Lady's Hospice. I suppose just to give a context to dementia in Ireland and also to post-diagnostic services in Ireland, as most of you are aware, there's over 55,000 people in Ireland living with dementia, and this is expected to double in the next 20 years, which is going to have a significant impact on our health services. I guess the evidence that's out there and the research suggests that when someone is given a diagnosis of dementia, they should have access and timely access to post-diagnostic support services. Unfortunately, across Ireland, there's limited access for people to these services. And I guess with this in mind, also giving a diagnosis without access to these services can actually be detrimental to the person living with the condition and to their carers. The evidence that's there, I guess, in relation particularly to CST, there was a recent review done of the post-diagnostic services in Ireland, which did highlight that there are many benefits to cognitive stimulation therapy, and that in itself is under-provided within Ireland. I suppose, given all of this research and information, in conjunction with the National Dementia Strategy and also national guidance for people with dementia, that really prompted the development of the post-diagnostic service here in Our Lady's Hospice and Care Services. I'm going to talk about that a little bit later on in the presentation, but first of all, I just wanted to talk a little bit about cognitive stimulation therapy. Some of you here may be familiar with it, but just to explain actually what the therapy is, it's a brief treatment for people with mild to moderate dementia. So it's provided in a group format. Each session has a structured format. There's usually about 8 to 10 participants, and there's 2 facilitators. So within the cognitive stimulation therapy that we're offering here, it's myself or one of the other occupational therapists, and there's also a healthcare assistant that's providing the group sessions. The aim of the sessions really are to actively stimulate the person with dementia within a group format, while providing, I suppose, a supportive and optimal learning environment. And then there's the social benefits of the group itself. So each week there's a different theme, and that's really, I suppose, giving the person a choice of different activities to meet the interest of the group. I suppose you can have people coming from lots of different backgrounds, and the themes are changed each week so that you're trying to capture, I suppose, their needs as well. This program is based on the Making a Difference manual that was developed by Dr. Amy Spector. So the evidence that's out there is based on this manual that we developed our service on. So that brings me to my next point. As the girls previously mentioned, evidence-based practice is essential in the current health system. So what is the evidence for CST? So CST has been shown to improve memory and quality of life for people with dementia, and there's been multiple trials that have shown this, which is really, really significant. In addition to this, it's also shown to improve communication and social interaction. This strong evidence really, I suppose, prompted the NICE guidance to have it stated within the guidelines, both in 2006 and 2018, which is the guidance on assessment, management and support for people living with dementia and their carers, and that CST, which is cognitive stimulation therapy. I'm kind of using them interchangeably. I'm sure people have caught up with the abbreviation, but that it's to offer the CST to people living with mild to moderate dementia. So that is the guidance, and that's what we need to be striving for as healthcare professionals. So what is the overarching aim of cognitive stimulation therapy and the program that we're offering here in Our Lady's Hospice? The first and foremost is to improve or maintain level of cognitive function. So things like memory, attention, concentration, all of those kind of cognitive skills, also problem solving. as well as this also to improve the quality of life for the person and the carers, to facilitate open communication in a supportive environment. And I think that this is a really important for the model of CST. The CST focuses on opinions rather than facts, and it focuses on the person's strengths rather than their weaknesses. So that's a really important part. And it's also, I suppose, to provide stimulation in a way that's really respectful for the person. And I suppose that it's a person-centered approach. So getting on to now the program that we're offering here. So we started this in 2019 back in March. And it's a 10-week program that we have been offering. So on week 1 and week 10, we do a pre and a post assessment. The weeks in between, so for 8 weeks, the people are offered a cognitive stimulation therapy group for once a week for 8 weeks, and it runs from 10:30 to 12:30, currently on a Friday morning. Initially, the structure on the day is people come in, and there's tea, coffee, refreshments provided in order to help the person really settle into the environment, and also encourages that social interaction kind of naturally in the environment that we have here. The carer and family support to mention as well, our medical social worker, Gabrielle, is offering a 4-week support group. And this has been really a valuable part to the post-diagnostic support service. In addition to this, from an occupational therapy perspective, we also meet with the carer at the pre and post assessment and provide information and advice to them. So the outcome measures that we're currently using, and I think it's important to note here, we've seen and we've talked about the evidence that exists already. It's already in the NICE guidelines. This is something that NICE have said it should be offered, but I suppose what we're looking at is this novel way in Ireland of providing CST, whether we're making an impact, and I suppose looking at service delivery here, how we can improve and move the service forward. So the outcome measures that we have focused on are looking at cognition. So the 2 measures that we use to look at cognition are the mini mental state exam, which I'm sure everyone here is familiar with, so I won't go into detail about that, and also a memory questionnaire. And what that looks at, it's rated by the carer and it's also rated by the person themselves, and it's their perceived memory functional ability. So there's different questions and they say whether they have an issue in different functional areas with those tasks. That's rated at the beginning of the pre-assessment and then again after the 10 weeks post-assessment. Similarly then, there's a measure of quality of life, which is rated by the person with dementia and also their carer, which looks at quality of life in lots of different domains. And then we looked at the subjective experience. So these are 2 qualitative, I suppose, feedback forms, and the participants themselves fill out the feedback form and the carer also fills it out. And when the carer is filling it out, I suppose it's important to note that they're filling it out in terms of how they perceived their loved one or family member got on within the programme. So the inclusion criteria for our service here, the person needs to have a diagnosis of dementia. We have, I suppose, said it should be within the moderate stages of dementia, and that's because Aisling, my colleague, will talk later about the SMART programme that are covering the mild stages of dementia. Our service looks at people with an MSE below 20, but I suppose what we've said there to referrers is it's important that they consider the person's ability to actually participate within the group. They need to have somebody with them for the pre and post assessments, so whether that's a carer, a family member, a friend, they need to be able to see and hear reasonably well in order to participate in the group. We obviously make exceptions within the older population. We do have a lot of people with hearing difficulty. It's not to exclude them, it's just that they need to be able to engage with the group at some level. The referrals that are accepted at the moment are from consultant geriatricians here in Our Lady's Hospice, in St James's Hospital and in Tala Hospital as well. I suppose just to note with that, this is, I suppose last year was a pilot phase and we will be looking at our referral process as well down the line. So in terms of feedback, so this was a pilot project in 2019. So we ran 3 10-week group programs. And I think this was, I suppose, when I looked at how many sessions were attended by participants, this is really significant to us. On average, there was 9 out of 10 sessions were attended by the people with dementia. There were trends towards improved quality of life and improved cognitive functioning, and there was really positive feedback, particularly in relation to mood and communication, which I'll talk about now. So within the subjective qualitative feedback forms, people are asked, how would you rate your mood following the group? So the people who attended the group and their carers felt that overall mood was improved by 80%. So 80% felt their mood was improved, 20% said no change. So 80% is pretty significant. Do you think the group helped with your communication and interaction skills? Again, 76% felt that it did, and 24% felt that it may have. So again, quite significant. Just to give some of the quotes and some of the feedback from the participants and their carers. So this is from a gentleman who was in one of the groups. It was fun and felt good and comfortable with everyone. I was not rushed, I gained confidence. And just another one here, I'll read from a carer. Yes, the programme makes people like my mother feel special and important. Therefore, I would be more inclined to promote the great job the staff do in managing and caring for people like her. The last one there, yes, because it benefited us as a family and improved mood. And I think that's also testament to the social work group that's running in conjunction with the CST. So when people were asked what aspects they found most beneficial, the common themes that arose were really around having a safe environment, not being rushed, a bit of humour and fun. And that comes back to the way that CST is delivered, and that it should be in a very person-centred way, and then interacting with others. So just, I suppose, a quote there, it is sense of comfort, good humour and a chance to mix with people and socialise. Love singing, and I really looked forward to coming here every week. So just my last slide before I hand you over to Aislinn, my colleague in St. James's, is just the plans for 2020. As I mentioned, this was a pilot project last year, and based on, I suppose, the results that we saw and also the feedback from the participants, it's now embedded in the service that we're providing in Our Lady's Hospice and Care Services as part of a post-diagnostic support service. We have agreed to offer 3 further 10-week programs this year. We hope, I suppose, to explore, we hope to explore other funding avenues and also to expand the service. I think it's important to note that we didn't get additional kind of resources or funding for this. It came out of kind of what we had at the time, and we had to reconfigure some of the things within the older person service. So we would like to, I suppose, further explore kind of funding avenues and obviously look at research opportunities. So they're the main plans, and hopefully we'll be able to achieve some of them this year. The first group has already commenced in January as well, and we have about 20 people on the wait list. And that's without doing another call out to referrers as well. So thank you very much.
So thank you for that, Claire, and thanks for having me here today. So I'm Aislinn, I'm a senior occupational therapist working in St. James's Hospital. So I'm here today to tell you about the Specialised Memory and Attention Rehabilitation Therapy Programme, also known as the SMART programme that we run in St. James's Hospital. So then our SMART programme is based on a cognitive rehabilitation approach. So according to the NICE guidelines in 2018, cognitive rehabilitation refers to the improving or maintaining functioning in everyday life, building on a person's strengths and finding ways to compensate for impairments and supporting independence. So Mary McGrath, who's an occupational therapist working in the Belfast Trust, set up the home-based memory rehabilitation programme for people with memory difficulties. A randomised control trial took place of the programme's effectiveness, and there was very positive results. In 2019, a memory strategy education group intervention article was published by Anya Coe in NACE General Hospital, and findings from the programme also suggest positive outcomes that were maintained at a 3-month follow-up, and thus support the role of occupational therapy in providing occupation-focused memory strategy programmes. So as we all know, post-diagnostic support is so important for people who've been diagnosed with dementia. According to the World Health Organization, post-diagnostic support refers to enabling people with dementia and their care partners to come to terms with the disease, plan for the future, and make best use of their current circumstances. So the Next Step guidelines were published in 2019, and they state that post-diagnostic support should include interventions, therapeutic treatments, and activities that build on strengths and abilities that help to maintain and enhance quality of life. As I'm sure most of you are aware of the Irish Dementia Working Group, so they're a group of people who've been diagnosed with dementia, and they state that in post-diagnostic support there should be peer support, cognitive rehabilitation therapies, social contact, and sharing of information. So how did we come about providing this SMART cognitive rehabilitation program in St. James's Hospital? Well, it was identified from the occupational therapy department that there was a need for a cognitive rehabilitation resource for people with dementia in our area. Historically, there was no occupational therapist linked with the memory clinic, which was set up in the medicine and for the elderly department. So in 2017, we did a pilot project called the SMART program. It was aimed at people with dementia who were living in the community. 11 participants took place in it, and we completed outcome measures to look at the group's effectiveness. From the outcome measures, there were significantly positive results with the Referral Behavioural Memory Test and the Canadian Occupational Performance Measure. Unfortunately, we didn't have the funds at that time to continue running the programme. So in 2018, we applied for the National Dementia Office grant, and we're very lucky in securing one of the grants. So we're therefore able to run the programme on a year basis last year. So last year then we had 12 groups went through the programme. This year we've also been very lucky and have gained funding for 2020, so we will continue running the programme into 2020. So what are the aims of our SMART programme? So it's to enhance and maintain our cognitive abilities, to improve occupational performance and functioning in the community, to reduce the impact of everyday memory difficulties, to provide an opportunity for peer support, and to provide education and onward referrals. The inclusion criteria for the SMART programme is that the participant has to have a dementia diagnosis. They've to be living in the community with minimal supports. They have to have a mini mental state examination score of above 18. Currently, we're only taking referrals to patients who are under a consultant in St. James's Hospital, and they have to be able to participate in a group setting. So then what is the SMART programme? So it's a 7-week programme with a 3-month follow-up appointment. There are individual sessions on weeks 1, 7, and a 3-month follow-up where outcome measures are completed. So the outcome measures that we're looking at here are the Referral Behavioural Memory Test, which looks at different memory functioning. We look at the Canadian Occupational Performance Measure, which is a collaborative goal setting tool. We look at the DEMQUAL, which is the Dementia Quality of Life Questionnaire. We look at the Functional Independence Measure, which is a rating scale for function and cognitive aspects. And then we get the carer or the family to complete the DEMQUAL proxy and the Zarat carer burden interview. The group sessions then are in weeks 2 to 6. So the group sessions usually have about 5 people with dementia in the group settings, and they're encouraged to bring a family member or a friend along with those. The group settings then usually happen on the same day and the same time each week, and they're generally for about an hour and a half duration. So in the group sessions then, they're workbook based, and they focus on educational discussion and exercise tasks. So in week 1, we look at brain health and attention. Weeks 2 and 3, we look at understanding memory, so the different aspects of the memory and the different internal and external memory strategies, which aid with memory. Week 4, then we look at home environment and falls prevention. We bring the people with dementia and their family members or carers to our ADL suite in the hospital, and we show them different aids or assistive technologies that may help them at home. So things like a memory board, calendars, diaries, and things like orientation aids or safety aids as well. Then in week 5, we look at a program recap. So we go over kind of important aspects that we have covered over the last couple of weeks. Each week, then we have a tea or coffee break. So this is to kind of promote peer support for both the people with dementia and the family members and the carers. And then in week 1, we complete a Canadian Occupational Performance Measure. So that allows us to do collaborative goal settings. So each week we review on the goals that were set by the group members and see, are we meeting them? So then the first year we ran the programme solidly for the year. So we had 135 referrals and 51 people were allocated groups. As you can see from the pie chart, most of our referrals from the people who were allocated the groups came from the OPD geriatrician clinics with 40%. We had 33% from the memory clinic in St. James's Hospital. And we had other referrals from other HSCP colleagues, the Robert Main Day Hospital, consultants and community referrals. So in 2019 as well, we also ran 12 groups, and we're continuing them in 2020. We've already started our next 2. So then if we're looking at our results, so for the purpose of our results, we use the Wilcoxon rank test for statistical analysis. With that, we can see that in terms of our Referral Behavioural Memory Test, we can see that the raw scores improved from baseline to post-intervention, and these improvements were continued at a 3-month follow-up. There were statistically significant improvements in scores from baseline to post-intervention and from baseline to 3-month follow-up. And what this kind of means to us is that although we're providing intervention for the first 7 weeks, so pre and post, these improvements in scores are being maintained at a 3-month follow-up with no active input. If we look at our Canadian occupational performance measure, and particularly our performance scores, we can see that the median score is improved from baseline to post-intervention and at a 3-month follow-up. There have been statistically significant improvements from baseline to post-intervention and significant improvements from baseline to 3-month follow-up. And if we look at the Canadian Occupation Performance Satisfaction element, similar to the performance one, we can see that the median score is improved from baseline to post-intervention and at 3-month follow-up. And these are statistically significant improvements from baseline to post-intervention and a significant improvement from baseline to follow-up. This is similar with our Rivermead Behavioural Memory Test. We can say that the Canadian Occupation Performance, the results were maintained at the 3-month follow-up despite there being no active intervention. If we look at the functional independence measure, we can see that there were statistically significant improvements in scores from baseline to post-intervention and significant improvements from baseline to follow-up. In terms of the DEMQAL and the DEMQAL proxy, we have seen improvements with them, but just due to the low number that we had in the results, I feel like the more participants that we have, we'll have higher improvements in that. In terms of the Zara Care Burden Interview, so that measures stress levels among carers. So with that, the median was 30, which would suggest that there's moderate carer burden around this client group. We have had quite positive participant feedback. So you can see we have some photos there. I think people like the peer support aspect of it. So it was gratifying to know that others have memory problems, and as well like getting tips from other people. So I love speaking to other people with dementia and getting tips. A carer said it was very informative. Everyone got involved and the interaction of people in the group was very good. People took strength from each other. So in 2020, going forward, we're going to hope to continue the frequency of the groups. We've started developing pathways with other community sources like Claire and cognitive stimulation therapy. So we'd hope to develop these pathways further into 2020, and we're also going to continue collecting our research. So then kind of in conclusion, I suppose, looking at the differences between the CST program and the SMART program is that SMART program is for people with mild dementia with an MMSE above 18. They're living in the community with minimal supports, and they're being built, the strategies that we learn week to week are being built on each week. The CST then is for people with moderate dementia and MMSE below 20, and it's cognitive stimulation, not rehabilitation. So you don't need to retain the information from session to session. We'd like to take this opportunity to kind of thank the people who've been involved in the programs and have helped us to kind of get this far. So that's the National Dementia Office, the Dementia Services Information and Development Centre, consultant geriatricians, particularly Dr. Robinson and Dr. Purcell, OT managers and colleagues, and Dr. Ty Stapleton. So thank you for listening to us.